Good. And you given them instruction on that piece? All right, welcome everybody to our May seminar. This has been a long time. I think we probably started a year ago trying to get you guys to come. We're very excited about this. I think many of you know, so this is our Prevention Research Center's monthly seminar. And we try to bring folks in both in the community as well as investigators across campus to talk about issues that we think are very relevant to the work we all do in prevention. And I think as many of you probably in the room will, probably why you're here as well, we at the PRC also think that a lot of the trauma and the adversity issues are at the heart of a lot of the work that we need to be doing. So really excited to hear about what you guys are doing, as well as how I think the synergies that may happen with us as well as those in the audience. So let me do my other things. All right, so today, reminder that we have 2 more sessions. We'll have one in June and July. But we don't have a seminar in August. So our June session is Dr. Karukian is going to be here talking about opioid epidemic in Ohio. And then in July, Colleen Walsh, those of you who may know Colleen, will be coming to speak about the conceptions of the health equity study. She's now at Cleveland State, but has been an affiliation of the PRC for a long time. So please try to join us for those 2 meetings. So without further ado, I'd like to introduce Dr. Megan Holmes and Dr. Laura Voith, both from our Mandel School of Social Work, but more particularly in relationship to this new center on campus called the Center on Trauma and Adversity. I think we're all very excited about this new establishment, and I'll let you guys tell a little bit more about your work, but thank you both for being here. We appreciate it.
Of course.
Thank you.
Would you like to introduce yourself first?
Yeah, so just to give a little bit more information, I am an associate professor and director of the Center on Trauma and Adversity, and broadly my research looks at domestic violence and the impact on child outcomes, and in particularly trying to identify what are the protective factors that promote resilience.
Hi everyone, I'm Laura Voith. I'm an assistant professor. I've been at Case here for 3 years now, and my research also focuses on domestic violence, but I actually focus more on boys and men who might be at risk of perpetrating violence due to victimization or adverse childhood experiences that they may have experienced and have gone unresolved throughout their lives. So we are very complementary in our work together, but you'll hear a little bit more about that. Before we get started, in the spirit of our center, we always like to start, I do this with my classes, we do it actually for our center meetings, and we try to do it to the best of our ability whenever we come and bring people together in a space. So we're going to transition to more of a shared space, one that's more mindful, or having a mindful, if you can sort of enjoy the play on words. So you don't have to do anything but stay present where you are sitting. And so what I'd like you to do is just sort of take a little bit of time to notice what's going on in your body. Notice the flavors, if you're enjoying the soup or salad that you have in front of you, if you're enjoying a sip of water, just notice sort of the experience, right, of that flavor, of the texture, whatever that might be. If you skipped lunch, you can just take a few minutes to sort of notice your breathing. Is it sort of higher in your chest? Maybe you just came running in a couple minutes behind the 12 o'clock hour, or maybe it's a little bit lower, right, in your stomach, sort of a deeper breathing. No wrong way to breathe, just something to notice, right? And so what I'd like to do is just give you 30 seconds just to take that time and notice wherever you're at with your body, so that we can all come together in this space as we sort of move through the content for the next hour. Okay, you can bring it back, and as you're ready, sort of bring yourself back to the presentation. I felt like that was needed. Everyone really moved into that so easily. You must all be like, Jedi masters or something. But either it was very needed or you've done this a million times. But you guys moved into that really well. So at this point, what I'd like to do before we begin, and I'll turn it over to Megan when we do, is just do an introduction around the room. We'd like to get a sense of who's joined us today. So if you could provide your name, role here at the university in whatever capacity that might be, or if you're not at the university, just a description of sort of what brought you here today. Can I start at the front?
Yeah. Rachel Gardenhire. I'm from the PRC, where I'm a research and data analyst.
Susan Petrone. I'm at the PRCHN, and I do the communications and dissemination.
Barbara Rutherford, and I'm with Gardenhood Enterprises, and I'm just here to see the presentation.
Rachel Summer. I'm also at the PRC and the Wetland Center, and a social worker, so that's kind of what got me interested in coming today.
Elizabeth Benninger. I'm at the Wetland Center, a postdoc. I have a master's in clinical psych and a PhD in community psychology, and I've done a lot of community-based work around trauma-informed care and things like that, so I'm very interested in hearing your presentation.
Gwen Conley. I'm at the Wetland Center, and I'm a doctoral student in population and quantitative health science.
Lavina Joseph from COGC. I'm here because we do training on domestic violence, particularly for men, and just want to hear what you're doing here.
I'm Elaine Borowski, and I'm the director of the Prevention Research Center.
I'm Michael Householder. I'm in the College of Arts and Sciences at Case Western Reserve. I teach a course in bioethics where we look at promoting health equity, but focus specifically on maternal and child health outcomes.
I'm Holly Brown. I'm supervisor of Moms and Babies First, and we are focusing on the ACE test. So we are looking into trauma and domestic violence.
Hello everyone, I'm Sampurna Sakya. I'm second year pediatric resident in Cleveland Clinic.
My name is Jake Sahun. I work at the PRCHN on the Youth Disability Research Project.
I'm Catherine Osborne. I also work at the PRCHN on the Youth Behavior Project, and I'm a doctoral student in medical anthropology.
I'm Alexandra Bowling. I'm a research assistant for a TTSD lab in the Department of Psychological Sciences at ACE.
I'm Chanel Upshaw, and I'm an intern with the PRC.
I'm Erin Harrington. I am a Master's of Public Health student in the Department of Quantitative and Population Health Sciences. I'm currently a graduate research assistant with the PRC. My main interest in this particular presentation is my areas of interest moving forward in research and thinking about doing my doctorate in public health is I'm interested in male childhood trauma and how that translates to unhealthy coping mechanisms and mental health disorders that kind of fuel some of the more negative aspects around masculinity in our society. So.
Maddie, do you want to introduce yourself?
My name is Madeline Castell. I also work at the PRC. I am the internship coordinator and also the seminar series coordinator.
Go ahead.
I'm Paul. I'm a postdoc at the Department of Physics.
Marika Nashka, formerly a research fellow in medicine in Harvard Medical School. I'm a health, fitness, and performance coach and professional, and I'm launching an independent business. I coach youth athletics, and I'm very interested how, given the same background of hardship, socioeconomic disadvantages, some youth go ahead and earn national medals and break records, while others are getting themselves into trouble.
Sarah Gonzalez. I'm a research associate here at the PRC, and my dissertation research was on children's experience of communal violence, and so I'm interested to see this presentation.
My name is Elizabeth. I'm at the PRC, and I work in research related to cancer and prevention.
Hi, I'm Jessica Jersak. I'm a coordinator for the Healthy Cleveland Initiative at the Cleveland Department of Public Health. One of our committees is violence prevention, and we're focusing on domestic violence right now.
My name is Brianna McIntosh. I work here at the PRCHN as the Community Engagement Coordinator for the REACH project and also the Clinical Transitional Science project. My work on the REACH project is more community-based and does a lot of work around the corner stores. And we're trying to make corner stores healthier place, not only by food, but also creating them as like a healthy hub for services with mental health screenings and health screenings in general for blood pressure and things. So I'm interested to see if there could be information shared at the tables and outreach events around some of these topics.
Oh, there was a call for Robert Wood Johnson Foundation just recently, just in that area. You should look into it.
I'm Suzanne Johnson. I'm the Deputy Director here at the Prevention Research Center for Healthy Neighborhoods.
My name is David Naima. I'm a postdoctoral scholar with the Switzerland Center for Environmental Health.
I'm Informa as a point. I am interested in looking at the Cleveland Food Bank and their food assistance programs and the intersection of that food assistance with all the other social determinants of health and how your social network approach to bridge all those different needs.
And I'm India Gill. I'm a PhD student in the Department of Population and Quantitative Health Sciences, and my research interests are ACEs, toxic stress, child.
I'm Ellie Fody with the Mount Sinai Healthcare Foundation. We support a nonprofit and health system partners in screening for adverse childhood experiences and then providing trauma-informed care in the early childhood and clinical spaces. So we're excited to work on.
My name is Wendy. I'm a doctoral student at business and social work. I'm going to start working for Switzerland starting next week. So I attend this presentation because I want to get more familiar with this topic.
Hi, I'm Amy, and I'm an administrative assistant in the Cancer Center, and I'm just a fan of the summer
And I'm Anna Thornton-Matos, and I'm a project director here at the PRC.
Right. All right, well, welcome everyone. Part of the reason Laura and I wanted to hear more about who's in the room is because we do tend to draw an interdisciplinary audience whenever we're talking about this topic. Trauma more broadly, domestic violence more narrowly. So it's helpful for us to know who's in the room so we can make sure we address certain topics. So our agenda today, I'm going to talk just briefly about the Center on Trauma and Adversity because that was what prompted this invite. We were established about a year ago, and I'll go into a little bit more detail. Then we're going to move into the intersection of domestic violence and health and talk about what's the research say about domestic violence and how it's related to health outcomes. And then I'm going to pass it off to Laura, and she'll talk about integrating a trauma-informed approach and give a specific example of one of the projects that she's currently working on here. And then we'll have some application based to where hopefully we can open up quite a dialogue around this topic. So as I mentioned, we were established about a year ago, and this was a really exciting opportunity for our faculty to come together and think about what is one of the greatest needs here in Cleveland, as well as looking across the nation. And an exciting part was that we had a group of faculty that were all working on different areas of trauma and adversity, so looking at individual, looking at families, looking at community and systems and organizations. And so we came together and said, okay, we're already doing this research in this area, but how can we address what is happening in the community? And so we designed this center with the mission of reducing the impact of trauma, responding to adversity, and promoting resilience through trauma-informed integrated research and training. So that integrated research and training piece is really central to our center. We have these two main arms, and I'm going to talk about both of these arms, and as we're doing this work in the community, as we continue to expand, this is really central, that we never want to keep it just as research or keep it just as training or practice, but really that there should be overlap going throughout it. So our research focuses on these three main pillars, so risk and protective factors.
So we know that trauma is linked to all these terrible negative things, but we also know that many individuals who experience trauma end up having just as good or better outcomes than individuals who have not experienced trauma. And so that question becomes, what are the protective factors that may be promoting that optimal development or optimal circumstances where this person can thrive despite experiencing that adversity? So a core focus of the research that our faculty affiliates are doing is trying to identify all those different protective factors at different levels of social ecology, so the individual, the family, and then the community, as well as looking at organizations and systems. The second pillar is developing interventions. And so we have a couple different ways that we're doing this. One is some of the work that Laura is doing around better intervention programs. So these have been in existence for a very long time. Some of Laura's wonderful work identified that many of these men going through the better intervention programs had their own trauma experiences. And so what she's done is redesigned the better intervention programs to have a trauma-informed lens and to address some of those early adversities that these individuals experienced. And those outcomes have been positive so far. That's an ongoing study. So we have other examples as well, but the idea is that we're trying to take a trauma-informed lens onto some interventions as well as developing new ones for this population. This third pillar is really exciting. So this is around transforming organizations and systems. And so an individual can experience trauma at an individual level, and then they can walk into a system and experience trauma again in the way that they've been treated. And so what we do is work with different organizations in helping them transform their organizations to understand what trauma is and understand what they might be doing might be triggering that individual to respond differently, which then ultimately, if we're thinking about a healthcare setting, may reduce the rate of them returning or seeking services or whatnot. So that's a core component of our research as well. Now on the training side, we are, as faculty members in the School of Social Work, are very interested in training our students on trauma. So we have, over the last 2 years, even before this center was formally established, have been building out a curriculum around trauma. And so we actually just passed a new graduate certificate in trauma-informed practice at the Mandel School that's going to be offered starting the fall, which is a very exciting endeavor. And we're hoping that this starting as a certificate will continue to grow and build our courses as we move forward. We have a specialized trauma fellowship training program. This is one in the nation. We have been asked to partner with Dr. Bruce Perry and the Child Trauma Academy and bring his model of neurosequential model therapeutics to the Mandel School. And so what this is a brain-based model of assessment for trauma. And so we know as an individual experiences trauma, the way their brain develops is impacted by that. And so if you send an individual to talk therapy, which is all our evidence-based practices, they may not be able to respond as well. And so this model identifies the areas of development in the brain from the base up and helps them build those capacities. So that one is launching next fall, and so we'll be recruiting students to hopefully join that fellowship training program. The other piece, which has been a very large component of our center, is delivering resources and resources to practitioners and organizations. And so this, we have been inundated with requests for training, for how do we help this certain population, how do we help our colleagues, how do we help us as clinicians. And so a core focus this last year has been on secondary trauma and trying to reduce the compassion fatigue and burnout that individuals in the field of trauma across all disciplines experience. So I have some handouts that were on the table out there, and you're welcome to take them. One of them is a really neat program that we started up a couple months ago that we received funding from St. Luke's Foundation called Healing Network Nights. And so this is a program that's a drop-in once a month in the evening. We come together and we talk about the ups and downs of being in the field of trauma. It's transdisciplinary, And what we're doing is trying to support this workforce that's doing this really hard work. It's hard work. It's hard work to be in the field of trauma, and to help them continue on, because often people burn out because they think it's something they're doing wrong, they think they might not be cut out for it. But the reality is that it may not be, it may be that the support has not been there for them, and they haven't been able to communicate this with somebody else that has a shared experience of this compassion fatigue. And so we've had a great turnout, between 60 and 40 people show up each month across disciplines to chat about it. So there's a flyer out there, it's the 4th Thursday of the month from 6 to 8, and there's free dinner, which is also lovely, and we provide self-care resources. I'm happy to chat about other things after the talk if you're interested, but I'll move into our core content today, which is the intersection of domestic violence and health, and this integrating a trauma-informed perspective. So this was a map that I created in 2013, and it was in partnership with the Domestic Violence and Child Advocacy Center. And they asked me to create this map because there were certain cities that were not reporting domestic violence incidents to that the police were not reporting their incidents to the state. And they wanted to know if we could get them, if we could put some public pressure on them to get them to report. And so I created this map that highlighted the certain cities that have the X's, so it's a little hard to see on here, that were not reporting. But it also highlighted the amount of domestic violence that was occurring across the county, and in particularly in Cleveland. And so what the national estimates say are that 1 in 3 women experience domestic violence in their lifetime. Domestic violence, defined by CDC, is physical assault, psychological abuse, sexual assault, or stalking by a current or former intimate partner. And what that translates to is 4.36 million women in the United States that experience domestic violence at one point in their lifetime. When we convert that to Ohio data, it translates to 1.55 million women in Ohio that experience domestic violence in their lifetime. And I should make a caveat here. I'm reporting, I'm speaking in terms of women, but domestic violence is not one direction. It's not just male towards female. It's not just male and female couples. It can go across any type of couple and go in any direction. There's been more research on women experiencing domestic violence, and the physical impact of domestic violence is more severe with women. So I'll be focusing on that part today. So this was the second map that I created for them, because we wanted to show that there's a national estimate of domestic violence that should be being reported, but there were a number of cities that were not reporting at the national estimate. And so we called this, the silent domestic violence survivor. So these are the women that are currently surviving domestic violence but doing it in silence. And what we see is, besides Cleveland, every other city was reporting below the national average. And
what
so,
is the zero silent? What does that mean?
So this is just the inverse of it. So it means that it meets the national average. So the 1 in 3 number. So then the question becomes, where are these women reporting, if they are reporting? And it turns out that many women actually report domestic violence in their primary care setting or other medical settings. And so we actually see higher levels of domestic violence being reported than the national estimates. So between 35 and 50% of patients in primary care settings report some form of domestic violence in their lifetime. That's a large amount. We also see high rates of emotional abuse in their lifetime, and a high rate of within the past 12 months. So 34% of women have reported physical assault by an intimate partner in the past 12 months. So hearing all of these statistics, we can say, if this was an infectious disease, we would have a treatment center in every single neighborhood. But the fact is that we don't. And there's many people that are still learning about domestic violence and understanding about it and the implications of how it relates to adverse health outcomes or other outcomes throughout the life course. So I'm going to move into some of the adverse health outcomes that have been linked to domestic violence, and I'm speaking from women who have experienced domestic violence and adults. I'm going to start with adults first. So the most common type of adverse health outcome is physical injury, and this range from minor injury to disfigurement to even as severe as death. And so what we see is that there's 2 million injuries reported each year related to domestic violence, and that 25% of the injuries that are coming in to the ER of women are reported by an intimate partner. With physical injuries, we often see that the injuries are blunt force trauma to the head, the face, and the neck. And with these, when there is an injury to the head, the face, or the neck, it's reported that between 81% and 94% are related to domestic violence incident. When a woman has experienced a blunt force trauma to the head, a third of the women report experiencing loss of consciousness during that incident. Strangulation is also very high among women who experience domestic violence. So of the women who come in to the ER who are seeking emergency medical care, 54 to 86% of the strangulation cases were by intimate partners. However, many of these are undiagnosed, is what the research is saying, is that a lot of times these are missed because physicians or nurses or whoever's doing the interview with them aren't asking specific questions about domestic violence or asking specific questions around strangulation, which in the medical field, you know that is a really high risk of death, of later death, soon following strangulation. And then the most severe physical injury is death. And what we see is that there's 1,300 deaths related to domestic violence each year. And of all of the women that are killed, a third of them are killed by their intimate partner. And so these numbers are astonishing, right? They're huge. Yet we still don't have enough programming. We don't have enough resources for these women and these families that are going through this. So I'm not going to go into all of these, but there's a very wide body of research that has been conducted in the relationship between domestic violence and all of these physical outcomes, and I provided a handout out there that lists all of the different, if you want to hold that up for a second. Yeah, so this one, so it lists all the different types of health consequences linked to domestic violence. So feel free to pick this up. Just for the sake of time, we don't have time to go into each of these. So in addition to domestic violence being related to these adverse health consequences, we also see that there's a dose response. So meaning that as the frequency and the severity go up, as the co-occurrence between types of domestic violence go up, we also see the severity of the health consequences increase as well. So I've talked about a lot of these health outcomes, and the CDC has done research on looking at the numbers of individuals that have sought medical treatment because of domestic violence, and these numbers are large as well. So all of these are related to individuals seeking treatment that was a direct link to domestic violence per medical record. So over 800,000 women had overnight stays directly because of domestic violence. This is in 1 year. Outpatient visits, ambulance calls, emergency department visits, all of these. So of the women seeking emergency care, this was 11 to 30% of women who sought emergency care were seeking it because of domestic violence. So of course this translates to increased health costs, right? Because they're seeking more medical attention, we've got increased costs. So per 1,000, so one study suggested per 100,000 women, we have an increase in health costs of 19.3 million. You can read the percentages there. There was a recent study done, which I think I have it on the next slide, that just came out this year that looked at the economic burden of domestic violence. So this is looking across healthcare, crime, productivity loss, criminal justice involvement, which translates to $3.6 trillion in economic burden across an individual's lifetime. So translated to Ohio, that's $160 billion that we incur. Interestingly, the government pays 37% of that. So you can see the numbers there that were translated. The one before that was done in 2003, so Laura and I were excited to see this come out because it is a huge issue, and often dollars talk when you're talking about a problem. Okay, so I've talked about the mom. What I haven't talked about are the kids. So often these women who are experiencing domestic violence also have children in the home. The majority of them have children. And the estimate is that 15 million children are exposed each year to domestic violence. And when we look at between the age of birth and 18, it's 1 in 4 children are exposed to domestic violence. So that's a large number of kids. When I'm saying exposed to domestic violence, I'm talking about the child does not have to directly see it. We used to use the language witness domestic violence. We now don't use that language anymore because we know that even if a child doesn't see the one caregiver striking another caregiver, they experience the aftermath of it in different ways. So that could be seeing broken plates on the ground, experiencing the mother's response to it through her mental health, through her anxiety and fear, or potentially intervening, trying to stop the violence between the caretakers. So this is a map that I created, it was about 2 years ago now. So I aggregated data across the state that had multiple forms, that reported domestic violence across different systems to produce this estimate by county. And what we estimated was that 168,000 children in Ohio are exposed to domestic violence each year. And if you look at Cuyahoga, we are one of the highest percent in the state that we have the highest. So it's over 6% of our kids are exposed each year to domestic violence. So then, of course, these translates to different outcomes that impact the kids. And part of the work that I did was publishing a white paper that talked about all the different research that's been done on the impact of domestic violence on child outcomes. So that's available on our website. You could pull it down from there. I'm going to focus just on the health, the physiological, and the mental health piece today. So this was a systematic literature review of studies that were conducted looking at kids from birth to 18 and looking at the impact of domestic violence on child outcomes compared to children who are not exposed. And what we see across the literature is that that domestic violence is related to poorer health outcomes. So reported general health being lower compared to those not exposed. Children between the ages 0 and 3 not meeting their developmental milestone for language, for personal, social, as well as fine motor adaptation. They're at higher risk of asthma in early childhood if they've been exposed to domestic violence compared to kids who have not been exposed. For body mass index, one study did a longitudinal examination of domestic violence experience prenatally as well as just after birth, and what they found was that kids who were experienced prenatal domestic violence were at 6 times higher risk of obesity during adolescence than those kids that were not exposed. And then poorer sleep, so having more difficulty getting to sleep, more wakings during the night, and just less sleep in general. The link to the physiological aspect, I think, is pretty intuitive. So when we experience stress in our bodies, it affects our hormones. And so what the research shows is that kids who have experienced domestic violence have higher cortisol levels and lower RSAs compared to those kids that have not been exposed. And then the mental health piece is we see across the board that kids who experience domestic violence tend to experience internalizing symptoms, higher rates of trauma symptoms, more difficulty with emotional regulation during preschool, and then negative affect and self-blame also comes up in the literature as well in this area. So this was also part of a study that I did where we estimated the economic burden of kids being exposed to domestic violence. And what we found is that for the nation, it's $55 billion over a child, or for children who are exposed to domestic violence. In Ohio, that's $2.2 billion of economic burden. So before I pass this off to Laura, because that was all like really heavy and sad, the one part that I just wanted to say, which I started the conversation, is that not all kids end up having these poor outcomes. So while statistically they are more likely to experience this, when you look at the data, it actually shows that there's quite variation in child outcomes. And some of our more recent work has been mapping out developmental trajectories of kids across different domains, so academic functioning, internalizing, externalizing, and pro-social skills. And what we see with kids who have experienced domestic violence as well as maltreatment is that we see basically between 40 and 60%, depending on the outcome, are resilient, meaning that they may start at a lower functioning, but over time they increase, or they're just as high at meeting, standards for all those different layers of, or domains of functioning that I talked about. So we are, as I mentioned, trying to identify, what are those factors that are contributing to the resilient piece. So I'll pass it off to Laura to talk about trauma-informed care.
Sure. And I just want to clarify, we have until 1:15 total, yes. So we want to work in questions. Great. So one thing I just want to add on to Megan's last comment is the term resilience, which I'm sure many of us, if not all of us, have heard. I just want to also acknowledge it's not a trait, right? It's not like you're resilient or you're not. It's really something you can foster. And it's really domain specific as well. So it could be that a child or a person is very resilient in school, right, but maybe less resilient in a different domain, right? So think about it as something that we can really foster and we can really promote, and that it's going to look different with every person in every domain, also culturally specific, culturally relevant as well. And so that sort of is our transition, right, to trauma-informed care in ways that we can promote this with adults and children alike. So there are 6 principles. Ooh, I see we have a little bit of, don't worry, I'll read them to you. Six guiding principles of what we call trauma-informed care. Trustworthiness, peer support, collaboration, empowerment, safety, and then history, gender, and culture. So these are obviously broad. They're sort of guiding principles in that sense. But what I'd like you to at least take away from it, if you haven't heard these before, is that building that sense of trust is incredibly important and something that you can prioritize, frankly, regardless of the work that you do. And if we think about what we know with trauma and how it affects the body and sort of one's worldview, there's a lack of trust with others based on experiences that you might have had early in your life, right? So that's going to be really critical for folks to feel like they can move forward in whatever kinds of services you're offering. Peer support, also incredibly important and really sort of lends itself towards self-advocacy and independence, right? That people really can do things for themselves if they have the tools that they need to do it. Collaboration is also really key. and thinking about how you work with people, right? So lots of us, in my guess, and this is something very true in social work, is we're often in positions of power, right? And so we're working either with community members or patients or clients in a way that we're really in charge of a lot, and we control a lot of what can happen for them. And so how you interact in a way that's as collaborative as possible, given the constraints of your own job and functioning, is also incredibly important for folks to feel heard, feel that they're a part of it. Empowerment lends itself to that as well. And safety is incredibly important. That's actually one of the first things that's going to be really set up the rest of these things. If folks don't feel safe in the environments that you're interacting with, the rest of these are going to be very challenging to be able to accomplish. And safety, I always like to give the caveat, is kind of an elusive term, right? Can we really create safety for people? I would argue that we can do it in gradients, right? So we can create a safe space in this room to the best of our ability, but when folks leave this room, some of that is out of our control, right? So if you're working with folks who live in an unsafe neighborhood or community, right, what is the level of controls that you have to establish a sense of safety with people? It might be a sense of psychological safety, might be physical safety. And then what really runs through these principles is that last one, history, gender, and culture. There's a term that you all may be familiar with, but intersectionality is a really incredibly important piece to all of these other principles. Understanding what kinds of identities people occupy, right? So whether it be gender, whether it be their sexual orientation, race, ethnicity, religion, etc. Those are all parts that make up that person, right? And how does that identity that they have really lend itself to the power dynamics, right, that are existing in whatever way you're working with that person. And so being really mindful about those, that intersectional identity in the context of power, right, and the power that you have, that they have, and that our society sort of lends itself to, is really what sort of runs through these other principles. So I get that that's sort of broad and big. And so there are four sort of tenets that guide working in a trauma-informed, using a trauma-informed approach. Realizing, responding, recognizing, and seeking. So realizing is really where to start. First off, just basic knowledge, realizing the widespread impact of trauma and how it can really manifest for folks. So we were talking a little bit when we began, but there's enough research out there to show that everyone has likely experienced at least one adverse childhood experience, right? There are folks who are disproportionately burdened by experiencing more, right, adverse childhood experiences, and that is political. That is lends itself to race, class, gender, all of those different identities that I spoke to. But understanding whoever you're working with, I'll use the word client just to keep it basic, but whoever you're interfacing with, that it's likely they have experienced to some extent some adverse childhood experiences, and that their demeanor and their interactions with you are likely informed to some extent by those experiences. Recognizing is then really understanding what does that look like, right? If I'm interacting with someone and they perhaps are triggered by something that I didn't understand because that's not my life experience, and now they're interacting in a way that seems somewhat hostile or aggressive to me, but me having a trauma-informed approach will know, you know what, this probably isn't really about me. How can I interact with this person that will allow them to sort of regain a sense of control from whatever sense of control they might have lost, right, and whatever happened that I'm not seeing, and allow us to sort of bring back to a space that's going to be safe for them, safe for me, right? And how do we do that? And that could be something extreme or minor, right? So even just thinking about interacting with your colleagues, right? You know, if someone's having a bad day, right, how do you interact with them that either enhances that, right, and exacerbates the issue, or maybe sort of lends itself to folks sort of getting their space to cool down in the way they need to. Responding is then integrating this knowledge that we have, both in the prevalence as well as the manifestation of it, into our policies, into our procedures, into our protocols. And so for the researchers in the room, I recently did a study where we really integrated this into the active research, right? So that was just coming out of Trauma Center and doing the work that we were doing, we knew that was central. The men that we were working with, the entire study was predicated on the idea that they were going to have experienced ACEs, adverse childhood experiences. How could we ask them about these incredibly sensitive things and not be trauma-informed in the way that we're doing it? So there are so many ways that you can apply it, whether it be service provision, whether it be research. There's just a number of ways that you can be very thoughtful about how you're going to not only interact, but your procedures, your protocols as well. And then finally to seek, right, actively resisting re-traumatization. So Megan started off the talk by saying folks come in who've potentially experienced adverse childhood experiences and perhaps continue to experience them as adults. And then we or others who we work with interact with them, right? And do we sort of re-victimize them? Sort of a relevant and in my wheelhouse example would be with women who've experienced domestic violence or sexual assault, having to retell their story to the SANE nurse, to the prosecutor, to the cop, to the community organizer who's like bringing them around to services, right? Having to retell that over and over again is not a good thing for folks. Again, it doesn't empower them to share their story when they're ready, and it sort of has them share it with folks who they may not trust, right? To be able to care for that information in a way that they want to. Right, so thinking about what are the things that we're doing that might re-victimize folks. So there's 3 levels in which you can think about this, or that are typically thought of for this, which is the highest, and I would argue maybe hardest to achieve, is a system or organizational level. Then there's staff level and an individual level. There's really, so the sort of common sort of way that people have thought about this shift, it's really a paradigm shift, really a shift in how we think about problems, how we think about solutions. The question that people have asked for so long is, what's wrong with you, right? What's wrong with this person? You know, they're yelling, nothing even happened, or they're completely, you know, withdrawn, and I don't know what's going on. What's wrong with this person? What trauma-informed care, what that lens really shifts to is what happened to this person, right? Which is a very fundamental shift in how we think about problems and solutions. So I'll give you just a quick example of some of the work, or one of the projects that I'm working on that's really attempting to implement this idea of trauma-informed care in it. And so it's a hospital-based violence intervention program that I'm partnering with university hospitals, Rainbow Babies and Children, as well as the Poverty Center, which is housed as well in the Mandel School of Applied Social Sciences. So there's this, you know, terribly unfortunate circumstance that children, we're focused on ages 6 to 15, come into the emergency department with either severe assaults or gunshot wounds. So these are very high-risk kiddos. Linking it to, right, our broader talk about domestic violence and health, children ages 0 to 12 that come into the hospital, the emergency department with these very severe injuries are usually there because of a domestic violence incident in which they were either trying to intervene or were somehow caught in the middle of it in some way that has led them to come into the ED. So in between 2016 and 17, just under 200 children came in with these very, very severe injuries. 35% of them were gunshot wounds, and 65% were these very severe assaults. That's not alone incredibly challenging. What's even more challenging is that the likelihood that they will return within a year's time with a very similar injury is about 30%. Right, so we see this not only initial incredibly challenging experience, but that the risk is high that they will return. So this is, you know, luckily there's really fantastic people working at UH that see this, that see that they're only able to do one piece of it, right, is that they do the recovery care for those kids, but then what happens when they send them home? And so they really wanted to partner to try to understand, lens, right, of adverse childhood experiences, that there are multiple things going on in this child's life, and how do we, right, we being UH, really ensure that these kiddos are not coming back. And so we are enacting, designing, enacting, and testing a trauma-informed program, right, that works with these kids. So some pieces of it are that, one, the pediatric division is working to become trauma-informed. And so this is incredibly important because when these kids come in, on the one hand, you might think, so the program will pair a social worker with the kid for at least 12 months post, and that social worker uses a trauma lens to assess strengths, challenges, and really try to provide wraparound holistic care to target protective factors that promote resilience, as well as ideally lend itself towards something called post-traumatic growth, which I'll come back to in a second. But what's incredibly important if you think about this is so much of this intervention actually doesn't happen in the hospital. It actually happens outside of it because it's 12 months post their exit from the hospital. So those kids may be there for a month with recovery, depending on how severe their injury is, but they, so much of it really is again, in their life circumstances that occur in the community. And so the ability to get those kids on board is an incredibly important aspect of this program. And if you might think, of course, like there's this like crisis, this child, of course they're going to want to be a part of it. But actually some of the older kids are in there because they've also are both victims of injury or violent injury, but are also perpetrators, right? So that they're involved with crime as well. And so they might be so caught up in a life that doesn't really necessarily lend itself towards, hey, let me change my trajectory and get on this path with a different program. And so how hospital staff interact with those kids in that moment is incredibly important to make that connection. And if you have a kid who was shot, but also maybe shot another kid, you might approach that child with not the most compassion and care, right? You might think, well, this is a bad seed, this kid did something bad as well. That is not a trauma-informed approach, right? And we're not going to be able to utilize that teachable moment in a way that's really going to impact their lives. So having that trauma lens is incredibly important in this hospital staff. Also, folks working in hospitals see the worst of the worst, right? They're in and out, and they're victim to compassion burnout, right? That's just like so many of us. And so really getting folks on that page is incredibly important. With that said, I know we have almost no time. I want to be really thoughtful that we have time for discussion. But I'll just say having that lens of gender, history, culture, race is so incredibly important to being able to connect with these kids, right? So it's really an embedded approach. So it's not just having the knowledge, but it's also having the skills to be able to interact in a way that that kid is going to feel heard, that's going to feel safe, and feels like this might be an option for them. Other things that I want to note is the nod that I gave to this idea of post-traumatic growth. These 5 elements that I've highlighted here are really sort of the core components to the program to promote resilience within kids. What I think is going to be incredibly important as well is this transition or this transformation for post-traumatic growth, which is really, not only have I maybe returned to my baseline functioning since the injury happened, but I've made meaning from this injury, and now I'm going to move towards something that my life shifts because of this injury, right? So that's, I think, what's also incredibly important, and it's going to be vital to the success of this program. But I am thoughtful of time, so I guess what I want to end here is just a quick note towards thinking about how you can approach intervention or trauma-informed care. And you can think about it in terms of an intervention that I just described. You can think about it in terms of secondary prevention, as well as a provision of referrals, right? So there's a variety of ways you can really think about how to really to intervene with the impact of adverse childhood experiences with either children or adults. So with that, do you want to open us up for discussion?
Yes. Well, we can open up for questions, or we could...
Right. We'll, of course, take your questions, but we also just, yes, we'll take your questions. We just want to know how we can make this tailored to your work. Yeah.
We work with community health workers, so we actually work going as home-based.
Yeah.
And what I want to know is how can we expand this so we can actually get the training, because what's happening is we're doing the ACE test, and one of the things we complain about is that we're leaving the person open until they are connected to mental health services that could be from between 2 weeks or a month and a half to 2 weeks. So that person, we can only, we are trusted. That's the good thing. We don't take the ACE test. They don't take the ACE test. Probably we all do the ACE test. But anyway, they don't take the ACE test until months later. So we are trusted, and we're just kind of given, basic support as far as that's concerned. What is it that we can do as community health workers that we can be able to help this process? Is it a referral process that we can get specific trauma care, or what is it that we can actually do as far as our practices?
Yeah, I'll say so we do a ton of screening, and usually in audiences like this we do screen for ACEs because it's important to acknowledge that usually we're talking to a group of traumatized individuals. So when we do screening, we always pair it with the relational health questions, because that is an important indicator of whether the individual has those resilient, optimal type of outcomes. So often we ask those 10, 15 questions, sometimes if we're doing the expanded ACEs, and then a series of questions about who they have felt supported by, who they currently or who they felt supported by in their first 18 years of life, and then what locations did you feel supported by. So that, in using a trauma-informed approach in screening, you're essentially opening up a wound and then trying to help close it again by talking about some of the positive things. So that's
is it possible we could give that, because
we
in our ACE assessment test they just ask the question?
Yeah, we can. We're happy to share that with you. And we've modified it for different settings. So we were working with the City of Cleveland and the trauma-informed recreation centers, and so that was something that we implemented there. That we screened all the staff for ACEs, and we also screened them for the relational health questions, which is what I was getting at.
The second part of the question is that now you're going to be doing this dynamic stuff at University Hospital.
Yeah.
If we have clients that we come in contact with, they usually have older children. So even though that situation may not have happened where they actually saw the trauma, but maybe it's something that they're kind of living through because they got taken out the home or something like that. Is there something that we can do as far as, can we say, we want you to go to trauma-informed care at Rainbow Babies and Children, or even be able to give the information out that there is something available? Is that possible?
So in terms of the particular program that we're working to do, it's very specific to the children that come in the emergency department. However, actually, I don't know when it's coming online, but Megan was part of a project where they did an assessment of services, and I don't know if it's the whole state, but certainly in the county, that really examined who offers trauma-informed services, and that is meant to be put as a public tool for people. So do you have any sense of when that's coming out?
Yeah, we're in the midst of data collection right now. So we've partnered with Red Tree House, and it's a Department of Justice grant that we are in partnership. Case Western's in partnership with the AG's office, and so it's two parts: a screening tool that screens for different types of victimizations for children 4 to 12, and it's a pictorial screening. So meaning the child can answer the questions themselves rather than the parent answering. And then that's a digital tool that's linked to a resource directory. So after the child is screened, it indicates not only victimization but also trauma reactions, which is a little bit different than trauma symptoms, because trauma symptoms, a lot of times kids don't meet the criteria for the DSM trauma, post-traumatic stress disorder, but they have developmentally appropriate trauma symptoms. And so we've identified all of the evidence-based interventions that are effective in treating those symptoms. So once they finish the screener, then it links digitally to the resource directory, and you're able to identify within X miles of where you're standing these are the agencies that offer that service. So I'm happy to share that resource once it's available. We're still in the midst of building the, we're right now in the middle of data collection for building out the resource directory.
Okay, that'd be fun.
Yeah.
If anybody else is but
Yeah.
Yes. So my specialty, my area of expertise, developing expertise, I should say. I'm so
You can say it's your area of expertise.
Is psychological trauma and emotional trauma, not necessarily violence. It's often the case that 9 times out of 10, if you have physical trauma, if you have domestic violence, you are almost certainly going to have psychological and emotional aggression on the part of the perpetrator. And so I usually look at psychological and emotional trauma from a perspective separate from violence, but also together with it, because psychological and emotional trauma is weird because there is no visible sign of it usually. It is really, it's harder to identify, it's not tangible most of the time. So my question for you then would be, to the extent that you have looked at it, how are you guys engaged with this question, this kind of almost phantom creature of psychological trauma? Because I feel like that's really hard to do no matter what discipline you're in, and it's very abstract because it comes out in ways that can look like it's somebody who's also experienced physical or domestic violence, but they don't necessarily, do you see what I'm saying? They don't necessarily.
Yeah.
I always like the thing that is very hard to measure.
Yeah.
So,
Yeah, I'm happy to speak to it. So, yeah, I mean, your point is well taken. So as a society, as in terms of domestic violence, intimate partner violence, we don't see the bruise or the mark, and so it's very hard to appreciate, right, that someone might be in a violent relationship, even if it's not a physically violent relationship. And so research has been done on this, and it actually has just as bad, if not worse, effects than physical violence does. And I speak from a lens of intimate partner violence, so adults in a romantic relationship. And so the research, I'm glad more folks are going to be doing it, because I think we need to understand it better, particularly how do we use the information, right, to sort of help, almost like a public health message to society of what that looks like and how do you sort of help or intervene with it. And so, yeah, I mean, I think that in terms of ACEs, that is measured. So there's the traditional 10 ACE checklist, which includes emotional abuse as one experience of 10. There are expanded ACEs checklists that also have been developed since that get at different experiences, felt discrimination being one of them, so not quite psychological abuse, but maybe you could sort of group them in a way with that lens. So you can measure it, I think. I think the question is, what do you do with the information? How do we actually start to make impact, make change, so that we as a society, we as systems or organizations are screening for it, and then providing services or referral services, right, to have people to mitigate it, essentially.
is how you're right. You can measure it. It's harder to measure, but you can measure it. But no, you're right. That is the conundrum. Is how do you offer service? Like how do you design an intervention for that? Oh, there's my PhD. There's my doctorate. So yeah.
I was going to ask, so I'm going to push you to the other side of the model. So many of us are doing work on the consequences side. So we're not really focused on this side, but we realize that this is playing a role. So if you're looking at obesity and you're looking at depression or you're looking at these various kinds of even health behaviors, right? Now we know that this is playing a big role in these outcomes, but our focus is these outcomes, okay? So have you thought more about how to integrate, this is sort of my question I had to you early on, like how do you integrate these concepts and approaches that then, I mean, is it like an intervention mapping kind of thing where you take a known intervention that's for smoking cessation, let's just say, and now you're going to somehow overlay some sort of an approach on top. Is that how you would approach it? Like if you were looking at obesity and you know that trauma-informed care or trauma in the past has an influence on that, but obesity is your outcome.
Yeah.
What would you do? What would you do with the intervention itself? Would the intervention just be about the trauma, and that in itself would have an outcome change?
So yes, that would be my approach, but we're in different fields. So my focus would be work with the unresolved trauma and build up the relational health, so the connections with individuals where they feel supported. The neurobiology research supports that. It's the social element, the relational element that really helps with the healing of trauma.
Yes.
And so that combines, so dealing with the underlying trauma, providing a supportive relationship and helping them engage in supportive, positive relationships will have an impact on the physiological aspects that are happening in their body to realign, reshift some of those chemical hormones that are happening. That will then impact those health outcomes. That's my take. You might have a different take.
No, I think it's similar. I would not say, when you said overlay, I would say embed. Right?
Yes,
so I think
embedding
that's a different approach to sort of like we're just going to tag this on.
Yes.
But I think that it really, when I say it's a paradigm shift, it is, right? So if we're trying to, figure out obesity, right? And then we find out that childhood sexual abuse is really a critical component to, shame. I eat to protect myself, right? Yeah. That's a shift, right? In how you're thinking about the problem and potential solutions. And so off the cuff, I would say, there's things like EMDR, which is a well-researched, well-validated intervention that does intersect with that very interpersonal trauma that could also be, maybe that is sort of, we're going to try to change our policies to make sure our interactions and our procedures are trauma-informed, and then we're going to tag on this other piece to see if that starts to make a difference with this outcome of obesity, right? Because now we're also targeting what is sort of the underlying components to it.
Yeah.
But that's off the cuff, so I have to think more about it. Yeah.
This might be a good addition to that question. I was going to ask what some of those protective factors are, if there's any that are standing out more strongly.
Yeah, that's a good question. So my research has identified a number of individual protective factors. So children who have more pro-social skills, so they're better able to relate to others, end up having better outcomes in the long term. We've shown as a cross-domain relationship with aggression. So if they had more pro-social skills, later in life they had less aggressive behavior, regardless if intimate partner violence had continued. At the family level, having a caregiver who is responsive and warm. So this is sort of basic attachment theory idea that we have. One of the newer protective factors that I'm researching right now are sibling relationships as protective. So children in families of domestic violence, the caretakers are often not available and responsive because of the violence that is going on. So while that mother or the survivor can provide it at certain times, at other times they can, and particularly can't, particularly when the violence is occurring, siblings tend to go towards each other to provide comfort. And so what I saw in my clinical work, which is where I got this idea from, is that the kiddos that had better, strong, positive sibling relationships ended up having better outcomes than the ones that did not. So right now I'm researching those specific characteristics of sibling relationships that can be translated into an intervention to promote that positive element. Yeah.
Is there a primary prevention component in either your curriculum at the school or through the intervention study?
So I would say for us, for the intervention study I described, would not describe it as a prevention, just because it's so crisis oriented. But I think that there's definitely room for prevention. So I think, the prevention of what is maybe the question to begin with. So adverse childhood experiences do occur, and I don't know that I think it's a great goal to keep children from experiencing them, but I think we know that you're likely to experience at least some. Other ones that are listed on the ACEs checklist are like parent separation or divorce. So there's some things that, you know, you're likely to potentially experience. I think the prevention of like mitigating the effects early on, I think is where it's worth doing, just in the sense of how we understand things happening and then the potential outcomes that occur. And so, yes, I've worked with schools, not in Cleveland here, but I've worked with a school. We had a trauma-informed social emotional development program. I actually just not partnered, learned from them, brought them into my class here in Cleveland. There is ZenWorks Yoga. They come into schools and do a yoga session with the kids, and they do it on a sliding scale. So they actually go into, they're in Cleveland Public Schools, which has been really great, and they're working on testing it to see if we're starting to see different outcomes academically, less truancy, less suspensions, et cetera. And Ohio just passed a law that now has social emotional learning as a core curriculum component in schools. So now that's also the tricky part, is when you're going to embed like this prevention approach in various systems, is it an add-on or is it embedded? And so as an add-on, it's hard for teachers because they're like, oh, it's just another thing I have to do, and I don't have to report on this, so if something's got to fall off, it's going to be this, totally natural and understandable. So I think there's policy level implications of how we really embed this into systems from a preventative approach.
I think there's an easier and quite immediate opportunity for you relating to what Dr. B asked. Usually, especially smaller kids, when parents argue or are becoming abusive and they witness it, let alone when one of them leaves, they think it's their fault. So if you take that kid from the hospital and say it's not your fault, you need to understand that, have with them the discussion, and then follow them a few years and see those who didn't have your discussion, your little intervention versus the others, how does obesity fare, especially in girls. It wasn't your fault, and we had that discussion, and they made peace, and they even might have a support group at home, siblings, whatever. And the others who just got the trauma intervention and went home, cleared by the medical part. And see how did the BMI go from there.
Yeah, I think it's a bit more complicated than that, but because there's the physiological response and
so you can do it.
Yeah, the added layer of stress and what that does to the body. So just a child seeing parents fight, it raises that stress, all those hormones that go through the body, and that has an impact on later outcomes. But kids do need to know it's not their fault.
And they can be told at any time. Like I always think that's, even as adults sometimes.
Yeah, even as adults we can be told, it wasn't our fault for whatever we experienced.
I'm sorry to cut this off because I could keep asking, but if you have further questions,
we're happy to hang out.
Thank you both. This was